Thank you very much for joining me today. My name is Dr. Vijhani, and I'm an intensivist and a pulmonologist. And we will be talking about pulmonary hypertension today. I have no disclosures. We will first talk about the definition and the classification of this disorder. As we are talking about pulmonary hypertension, the symptoms are very non-specific, but they usually present with shortness of breath on exertion, which can move up to the shortness of breath at rest. Chest pain on exertion, which can progress to syncopal attack. When we look at the cardiac examination, there will be a prominent S2 heartbeat, pansystolic tricuspid regurgitation murmur, diastolic pulmonary insufficiency murmur, and S3 heart sounds. Pulmonary hypertension is actually detected using transthoracic echocardiography. When we look at the transthoracic echocardiography, it gives us the probability of a pulmonary hypertension, and it is divided into three categories: high, intermediate, and low. We actually look at the tricuspid regurgitation velocity, and depending upon the number, which ranges from 2.8 to 3.4, we divide it into high, intermediate, and low probability on the basis of transthoracic echocardiography. There are also additional findings which we look onto the echo to consolidate our probability. And those additional finding includes right ventricular and left ventricular basal, the right ventricular and left ventricular diameter ratio, if it's greater than 1, flattening of the interventricular septum, right ventricular outflow Doppler acceleration time, which is less than 105 milliseconds, and or mid-systolic notching, early diastolic pulmonary regurgitation velocity greater than 2.5, pulmonary artery diameter greater than 25 millimeter, and inferior vena cava diameter of greater than 21 millimeter with decreased inspiratory collapse, and right atrial and diastolic area greater than 18 centimeters squared. So these are some additional findings. We always look into the echo along with TRV to know that what kind of category we are dealing with. The next thing I would like to emphasize on is that pulmonary hypertension is actually a big group. We have to classify the pulmonary hypertension into various kinds because the treatment of every branch is different. Pulmonary hypertension is divided majorly into 5 classes, which are again subdivided into subclasses. The class 1 is pulmonary arterial hypertension. Then the second is group 2 is pulmonary hypertension due to left heart disease. The group 3 is pulmonary hypertension due to lung disorders and hypoxemia, which includes your COPD, obstructive sleep apnea patients, interstitial lung disorders patients, and obesity hypoventilation syndrome or obstructive sleep apnea patients. Then we have a special kind of pulmonary hypertension, which belongs to the pulmonary hypertension due to pulmonary artery obstruction. Now, it can be due to blood clot in the lung, chronic thromboembolic disorder, or a tumor or something compressing the pulmonary artery from outside, like a tumor pressing on it from outside or a lymph node pressing on it. Then we have pulmonary hypertension causes from the other causes, which includes the hematological causes like sickle cell disease, myeloproliferative disorders, or storage disorders, Gaucher's, mucopolysaccharidosis, and also sarcoidosis. So those disorders, we keep them as a group 5. Also the volume overload because of the renal dysfunction, hypothyroidism, they also come in the pulmonary hypertension due to other causes. Now, the next thing we're gonna talk about the evaluation of the pulmonary hypertension. Now, once we have the echo done, we have a probability that this patient may have a high chances, intermediate chances, or low chances. When we see the patients in the intermediate group, that's the time when we start working on evaluating the patient. Now, probability of pulmonary hypertension is intermediate to high group based on the transthoracic echo, and you have a clinical suspicion, then you consider getting an EKG, chest X-ray, pulmonary function test, polysomnography. You have to look for ambulatory and nocturnal oxygen studies, and also you may include the high resolution CT scan to rule out that it's not a group 2 or a group 3 disorder. Now, if your suspicion is that this is likely due to group 2 or group 3, and then no further testing is generally required. We also do a ventilation perfusion scan to evaluate for group 4 if the pulmonary hypertension is not fully explained by the presence of group 2 or group 3 disease. And then the diagnosis is confirmed by doing a right heart cath to confirm the pulmonary hypertension. And it is needed to distinguish WHO group 1, which is pulmonary arterial hypertension, from other form of pulmonary hypertension. Now, what is the definition of pulmonary hypertension on the right heart cath? It is the increased mean pulmonary artery pressure greater than 20 mmHg with pulmonary venous pressure equal to or greater than 3 Woods unit. Now, here is some definitions based on if the problem is actually the pre-capillary or it is post-capillary. So all the pre-capillaries pulmonary hypertension will have a mean pulmonary artery pressure of greater than 20 with wedge pressure less, because this is not a heart problem. So the wedge pressure should be low, it's less than 15. The PVRs are actually greater than 3. So you can rule out the group 2, because if the heart is involved, then you have PVR greater than 3, but your wedge pressure is less than 15. So the pre-capillary pulmonary hypertension, as we were talking about that, if your heart is doing okay, then your wedge pressures are less than 15, then you can rule out that it is a group 2. So with this kind of a presentation on a right heart cath with mean pulmonary artery pressure greater than 20, pulmonary wedge pressure less than or equal to 15, or PVRs greater than or equal to 3 Woods unit, you can rule out that this is not group 2. So what other left is 1, 3, and 4, and 5. If this is an isolated post-capillary pulmonary hypertension, then you will see that the wedge pressure is greater than 15. Then your mean PA pressure is greater than 20, and your PVR are less than 3. You can actually have group 2 or group 5. And if it's a combination of both pre and post capillary pulmonary hypertension, then you will see that your mean PA pressure, of course, needs to be greater than 20. Your pulmonary wedge pressure is greater than 15, and your PVRs are also greater than or equal to 3. In that situation, again, you may have you may be dealing with group 2 or group 5. So now let's talk on the pulmonary arterial hypertension, because in this group, we have a special class of medication and it is treated very differently from other classes. So what does pulmonary arterial hypertension mean? It's a pre-capillary pulmonary hypertension. So it is before the capillaries. The mean pulmonary arterial pressure greater than 20 mmHg. That's the definition you require to have a diagnosis of first pulmonary hypertension. Mean pulmonary arterial pressure greater than 20. Then your wedge pressure should be low. It should not be related to the heart. So pulmonary arterial wedge pressure less than or equal to 15 mmHg. The pulmonary vascular resistance should be equal to or greater than 3 Woods unit on the right heart cath. And in the absence of all non-PH causes of pre-capillary pulmonary hypertension. If I go back, pre-capillary pulmonary hypertension is 1, 3, 4, and 5. That means to have isolated pulmonary arterial hypertension, it should not be group 3. So you have to rule out that the patient does not have any significant hypoxemia or a lung issues. The patient should not have a blood clot or the other causes in which the patient should not have a myeloproliferative disorders or storage disorders or the kidney failure, volume overload, fibrosing mediastinitis. So you rule out all these, along with as you have all the characteristics of a PAH, pre-capillary pulmonary hypertension, you diagnose it as that this patient is group 1 pulmonary arterial hypertension. Now, once we have a diagnosis of pulmonary arterial hypertension, we also have to subdivide and subclassify into WHO subgroups from 1.1 to 1.7. And this is very important because we also need to know what kind of treatment patient requires and how frequently we have to monitor with the echo and the right heart cath on the patient. So group 1.1 is idiopathic. You do everything and you find nothing, but the patient has group 1 pulmonary hypertension. The second one is the heritable one, in which the patient has mutations in DMPR2, ALK1, and CAV1. Group 3 is drug or toxin induced because of cocaine, amphetamines, basically the adrenergics, and also weight loss medication. Group 4 is secondary. 1.4 is actually secondary to the connective tissue disorders, which includes lupus, rheumatoid arthritis, Sjogren's syndrome, and also the patients with HIV infection, portal hypertension in the end stage liver disease, congenital heart disease, including Eisenmenger syndrome, in which they have left to right shunt. Those group of patients are also considered in 1.4. 1.5 is the PAH, in which they are long-term responders to the calcium channel blockers, and we will talk more about how we assess the response to the calcium channel blockers. And actually, they have a very if they have a good response to calcium channel blocker, their prognosis is much better. Then we have a group 1.6, in which the PH has some features of pulmonary venous capillary involvement, which includes pulmonary veno-occlusive disease. We see that with Sjogren's or the transplant patient, bone marrow transplant patients, and pulmonary capillary hemangiomatosis. And the last one is group 1.7, which is persistent pulmonary hypertension of newborn. Now let's talk about the vasoreactivity test. Now, in this test, we actually use inhaled nitric oxide, adenosine, prostacyclins, and this helps us to identify the patients likely to have a long-term response to the calcium channel blockers. And this is performed mainly in the patients with idiopathic pulmonary arterial hypertension, heritable pulmonary arterial hypertension, or toxin-induced pulmonary arterial hypertension. Now, what does a positive response mean? When we give these medications to the patient and they already have a right heart cath, we looked at the numbers again. If there is a decrease in the mean pulmonary pressures greater than or equal to 10 mmHg, with that we are reaching to the total mean PA pressure less than 40, with including increased or stable cardiac output, then we say, yes, this is a positive response. So technically we need three things. One is the PA pressure should go down by at least 10 mmHg. Total pressure should go down by 40, keeping your heart and the cardiac output stable. So that is the acute vasoreactivity test. And that's the one in which we say the patient is positive on the test. Now, the next thing we have to look is what are the things that determine the prognosis in the patient. So for that, we have certain factors we take into consideration when we say that the patient is low risk, intermediate risk, and the high risk. And the why we do that, because the patients on a high risk, we have to start them on the medication so that we can bring them from the high risk to the low risk category by using multiple vasodilator therapy. So there are certain signs and tests we do to assess the risk on the patient. For example, if there is a patient has a signs of right heart failure, then they are automatically in a high risk group. That means they have a 10% chances of dying in next 1 year without the treatment. Similarly, if there is a rapid progression of the symptoms, the patient was short of breath, on exertion, but now it has progressed to the level that the patient is short of breath, even with the minimal exertion or even doing his ADLs, then it's a rapid progression. Then the patient goes into the high risk. Patient started having a syncopal attack that tells us that the cardiac output is low, RV is failing, and also when the RV dilates, it pushes the septa into the left ventricle, and unfortunately the LV diastolic filling also suffers. And in that situation, patients start having syncopal attacks when the high oxygen or a high heart rate is required during exertion. So if the patient started having syncopal attacks, they are already moving towards the high risk. Similarly, WHO functional class, and we will discuss about that in further slides, that if they are already in class 4, that means they are short of breath at rest, and it's a difficulty for them to do their ADLs without feeling short of breath. They are at a high risk. Similarly, we do a 6-minute walk test in our clinic. If they walk less than 165 meters, they are at a high risk. Similarly, the cardiopulmonary exercise test. Not every institute they do cardiopulmonary exercise testing, but it is good to have it as a tool to assess the patient, in which some factors are intermediate, some at high risk, and the patient is in between the intermediate and high risk to define where should the patient be placed. Then we also calculate the NT-proBNP levels. That tells us what's the strain on the heart. Higher the number, higher the strain, higher the chances of dying. And we use diuretics sometimes on these patients to get the preload out of the system, so that the BNP and the pro-BNP levels, they actually come back to the normal, or at least to a number where they are at the low risk. So BNP less than 50 and NT-proBNP less than 300. That's actually the goal. And also, as we were discussing, when you have a high pressure on the right side of the heart, the RA starts, the right atrium starts to dilate, and if the area is more than 26 centimeters square, and also there is a pericardial effusion, then these patients are at the high risk. And also, when we have a right heart cath, we also look at what is the pressure in the right atrium. If it's more than 14, your cardiac index is less than 2, or your SVO2 is less than 60. In that situation, the patient is at high risk. So this helps us to determine what's the prognosis of the patient and how quick we have to escalate the medications. Now, as we were talking about the WHO functional class, so class 1 is the patient with the pulmonary hypertension, but without resulting limitation of the physical activity. Ordinary physical activity does not cause undue dyspnea or fatigue or chest pain or near syncope. When we talk about class 2, there is a slight limitation of the physical activity. Patient is comfortable at rest. Ordinary physical activity cause undue dyspnea or fatigue, chest pain, or near syncopal attacks. Now, when we talk about class 3, these are the patients with pulmonary hypertension, which resulting into limitation of physical activity. They are again comfortable at rest. Less than ordinary activities cause undue dyspnea, fatigue, chest pain, and syncopal attacks. And the last one, which puts them back again in the high risk category, that they are unable to carry out any physical activity without a symptom. They have symptoms of heart failure, dyspnea, fatigue even at the rest, discomfort with any physical activity, and even a syncopal attack at rest or sometimes on the exertion. Now, when we talk about the treatment, as you know, that there is a high pressure in the pulmonary artery system, and so the main goal is to decrease the pressure in the pulmonary artery. So now how we do that? We use calcium channel blockers only in the patients who are responsive to the calcium channel vasoreactivity test. And there are certain other medications which we use, which are prostaglandin analogs, endothelin receptor antagonist, which work against the constrictors. We also use enhancers of nitric oxide, tadalafil, sildenafil. So those are the treatment options we have. We also have some newer generation of the medication like Rosiquad or Selexipag, and we will go into details. So let's talk about the pulmonary hypertension group 1 treatment. We will go over all the pulmonary hypertension treatment, but let's focus on PEH first. So in PEH group 1, we use calcium channel blockers for those patients who are vasoresponders, either alone or in combination with the PEH specific therapies. Now, there are some patients who are not the candidate for calcium channel blockers. For example, the patient has heart troubles, rhythm problem, or a right heart failure, in which higher doses of calcium channel blockers cannot be used. In that situation, we have to use the other medications as well. Then we have ambrisentan and tadalafil. The combination is recommended as an initial combination therapy in the patients who have a WHO class 2 and 3 symptoms over either as a monotherapy alone. So we always combine both of them. Again, as I said, that our goal is to bring the patient from a high risk to a low risk population by using these medications. So if somebody has a WHO class 2 or 3 symptoms, we start the combination therapy. Now, the other thing is that in symptomatic patient, which is unresponsive to the initial therapy, we also have used the various combinations which are safe and effective. For example, macitentan and sildenafil. Now, sildenafil is a nitric oxide enhancer, and macitentan, and then Rosiquad, and with bosentan, Selexipag to an endothelin receptor antagonist or a phosphodiesterase inhibitor, or we can use sildenafil with epoprostenol. The other thing is that whenever there is a slowness in the flow of a blood, there is always a chance of forming a blood clot. So we always consider an oral anticoagulant only in the patient with idiopathic heritable drug or toxin-induced pulmonary arterial hypertension. Although it's a weak recommendation, but sometimes we use it. And the patients with pulmonary veno-occlusive disease or pulmonary capillary hemangiomatosis, those patients are transferred to the higher center of care for evaluation for a lung transplant. Now let's talk about the pulmonary hypertension secondary to the left heart disease, or which is a group 2, or pulmonary hypertension group 3, which is secondary to the lung disorder and the hypoxemia. Very important thing to note that even though it is a pulmonary hypertension, it is not pulmonary arterial hypertension. So the combinations of medications which we were using, the endothelin receptor antagonist, the like busantin, macitentan, and the nitric oxide enhancer, tadalafil, and sildenafil, those medications cannot be used in these pulmonary hypertension patients. They can cause a very bad, serious side effects in these group of patients and even can cause death. So one take-home message is that treat the underlying cause of the group 2 and group 3. If they have a valvular problem because of the heart, or they have a left ventricular diastolic dysfunction, they have a left ventricular systolic dysfunction, treat the cause for that. Do not start them on a pulmonary arterial hypertension medication because they will have a very bad pulmonary edema and the side effects of medications. And so treat the underlying cause. Similarly with the COPD, ILD, the goal is to optimize their lung function, inhalers, and then based on the ILD, what we are dealing with, patient goes to either on the IPF or ILD secondary to connective tissue disorder or idiopathic steroids and immunosuppressive agents. Same thing in that condition. We do not add any PEH specific therapy, even though when we see that there is a pulmonary hypertension on the echo, we confirm that this is not group 1, and we do not start the patient on PEH-specific therapies. The other, you will always see the patients with the left ventricular diastolic dysfunction with COPD, sleep apnea. So they may have a combination of group 2, group 3. Sometimes the patient has a blood clot, which is dissolving, so they can have a group 4. So one patient can have multiple causes of pulmonary hypertension, group 2 plus group 3, and sometimes patients have CKD, they are a dialysis patient, they have sickle cell anemia, so there may be a component of a group 5 along with that too. So the main goal is to rule out that this is not group 1, because group 1 are treated very differently as compared to group 2, group 3, group 4, and group 5. Now let's talk about the group 4. Now, as I told you about that, it's actually the pulmonary hypertension in which there is a clot in the pulmonary vessel that causes increase in the pressure and the strain on the right side of the heart. And it could be because of the blood clot itself, which has not dissolved. Generally, 3 months are used to repeat the VQ scan and the echo again, because if somebody has an acute pulmonary embolism, they will have increased pressures in the right side of the heart because there is an acute obstruction to the flow forward. We treat them for 3 to 6 months with the anticoagulation, repeat the echo, we repeat the ventilation perfusion scan to see that the clot has resolved or not. If the clot has not resolved, then it is called chronic thromboembolic disease. And on the echo, we check the pulmonary vascular pressures, the RV systolic pressures. If they are normal, we follow them closely so that they should not develop the hypertension. Once they start developing the pressures in the right ventricular side, then they go towards the diagnosis of chronic thromboembolic pulmonary hypertension. In these group of patients, we need a lifelong anticoagulation. And one more thing I would like to emphasize, the patient may not need to have a diagnosis of DVT-PE in the past to have a diagnosis of CTIF, because sometimes these are very minor clots. Patients do not have any DVT history or a PE history, and you do a VQ scan and you will see that the patient has multiple clots in the pulmonary vasculature. So that's why it is a very strong recommendation that even if the patient does not have any history of blood clots in the leg or in the lung, before labeling it as a pulmonary group 1, we always get a VQ scan. And the other important thing is this is a very specific group of pulmonary hypertension in which you have to prioritize the diagnosis, because the treatment is pulmonary endarterectomy. If there is any obstruction in the pulmonary vessel, you take that obstruction out, and the patient can be treated and cured from the pulmonary hypertension. So, additional management should prioritize the pulmonary endarterectomy in the patients in which the occlusion is surgically accessible. If it's very paroxysmal, it's easier to take out the clot. But if it's very distal, then it's difficult. But again, if you have a diagnosis, you get the angiography, the pulmonary angiography, and find out what's the site of the obstruction. Is it distal or it's paroxysmal? And sometimes if it's not accessible, then we use Rosiquat for symptomatic patients in which it is inoperable C-TIF. C-TIF is again chronic thromboembolic pulmonary hypertension. Or if there is recurrent or persistent pulmonary hypertension after surgery, like somebody got a pulmonary endarterectomy, and even then there are some clots which are more peripheral, the surgeons cannot reach that area, the pulmonary hypertension cannot be fully resolved. In that situation, we use Rosiquat. Then also there is also another procedure which can be done is balloon pulmonary artery angioplasty, and this is for the patients who are not eligible for pulmonary endarterectomy. You just put a balloon and dilate it, and it's a very weak recommendation, but that can also be done if patient is not a candidate for a bigger surgery, pulmonary endarterectomy. Now, as we were discussing that, the group 5 pulmonary hypertension is treated same as group 2 and group 3. You have to treat the underlying cause. If somebody has sickle cell anemia, then you manage the sickle cell anemia, avoid any obstruction of pulmonary vessels with the sickle cells. If somebody has myeloproliferative disorder, abnormal blood cells, treat the cause. If they have a leukocytosis secondary to the tumors, try to decrease the number of cells with the therapy. Hydroxyurea we use sometimes, and try to decrease the pulmonary vascular pressure, because they start attaching to the pulmonary vasculature and cause increase in the hypertension. Also, the patient who have end-stage renal disease, the dialysis-dependent patients, keep them euvolemic by dialysis or diuretics if they are not end-stage renal disease patients. And also, if patient has sarcoidosis, LAM, or PLCH, which is a pulmonary pulmonary capillary lymphangiomatosis, those kind of disorders, we treat them differently so that they can be taken care of. And the pulmonary hypertension secondary to that is the same. It has the same treatment as group 3 and group 2. Do not administer pH specific therapies in those group 2, because the side effect of these medications is bad, and it can cause problems with the overall clinical picture with the patient. It may not benefit, but it can harm a patient. Now let's go over the take-home points. Pulmonary arterial hypertension is rare. Pulmonary hypertension is not rare. You will see very oftenly on the echo, mild, moderate, severe pulmonary hypertension is noted on the echo. But again, group 2 and group 3 are the most common causes, and worldwide it is schistosomiasis, and which is a cause of pulmonary hypertension. But in the United States, left ventricular diastolic dysfunction is the very common cause of pulmonary hypertension. So pH is common, but pulmonary arterial hypertension, which is group 1, is very rare. And again, it is underdiagnosed because patient may have multiple comorbidities. Patient may have a little bit of a heart failure. For example, if the patient has scleroderma, so they have a hardening of the heart, they will have a hardening of the vessels in the lung, they will have some interstitial lung disorder. So if that is not diagnosed, the patient will have a diastolic dysfunction on the echo, and they will have the ILD on the CT scan. So anybody who sees the patient, they say, oh, this is likely a group 2 or group 3. But, as we discussed, that pulmonary arterial hypertension, group 1 has a component with connective tissue disorders. So it's rare, and it is undiagnosed. Now, as we discussed, that we have to rule out that this is not group 2, this is not group 3, this is not group 4, and the patient does not have the symptoms and the characteristics of group 5. Once we rule out all that, then we say that yes, we are looking into group 1, and then we go for a right heart cath to confirm that this is what we were thinking. So careful diagnostic steps are necessary to ensure a correct diagnosis. We cannot skip or miss any step, because it will confuse the provider, and it can also lead to a wrong diagnosis. And again, I cannot stress anything anymore, but the most important thing is pulmonary vasodilator therapy is only for WHO group 1, which is your pulmonary arterial hypertension. Do not use them for group 2. Do not use them for group 3. Group 4 has a very different treatment, as we discussed, lifelong anticoagulation, the pulmonary endarterectomy, balloon angioplasty, Rosiquat, and not the other therapies for group 1. And why it is very important, because reaching for the therapy without careful determining the type or the cause of pulmonary hypertension can cause serious problems, including a preventable death, because these patients are very sick. The mortality of these patients are very high without treatment. So the goal is to catch this rare and underdiagnosed problem early, avoid any misdiagnosis, very careful diagnostic step, one by one we take. Treatment is only for group 1 with the pulmonary vasodilator therapy. Group 4 has a different treatment. Group 2 is secondary to the left heart disease, in which we manage the left heart disease so that the pressures in the pulmonary vasculature comes down. And the group 3 is the lung-related disorder, in which you manage the COPD, ILD, sleep apnea, obesity, hypoventilation syndrome, kyphosis or silicosis, and scoliosis. So, and group 5, based on what kind of a disorder we are dealing, hematological or mucopolysaccharidosis, we treat that cause. So we diagnose early. We try to bring the patient from a high risk to low risk. Very close follow-ups are required in these group of patients every month to 2 months. They always get a 6-minute walk test. When we start them on the therapy, we do not stop there. We monitor them. We get the right heart cath at a regular time. We also get the pro-BNP levels. We also get their 6-minute walk test, because if their heart is getting better, if the offloading is better on the right side, then and the pressures on the pulmonary vasculature is getting low, then the forward flow from the right ventricle increases, which helps the left ventricle too. So their 6-minute walk will increase, their symptoms will go down. So that tells us that the patient is on the right track. The second thing is, as the pressure goes down, their BNP level starts to come down. So that's again tell us that the patient is on the right track. And also we continue to monitor the patient with the scheduled the right heart cath, to see what the numbers are we looking into, what's the cardiac index now. We also get the echoes to look at the RA, pressure, the surface, the area, and also monitor that there is any pulmonary pericardial effusion or not. So, and then based on that, if the patient is not doing good, we go up. We go from a PO medications to IV prostaglandins, and then we transfer the patient for a lung transplant. So with all this, thank you again for joining me today. I know it was so much information, and if you have any other questions, you are free to reach me. My email address is drvijhanipraveen@gmail.com. Thank you very much, and have a nice day.